Hello, my name is Matt Lawler, EMS Captain for Augusta County Fire Rescue. Today we are going to discuss the iGel Airway, which Augusta County Fire Rescue personnel will begin using in September. As you're aware, the Regional Medical Control Review Committee has been preparing to introduce this device for over a year. The plan was to begin using the Airway this summer, but due to a variety of circumstances, the region-wide introduction of the Airway has been delayed until November. Your medical directors, Dr. Brand and Dr. Just, consider the expected positive impact of the device to be great enough for us to develop an agency-specific protocol and begin using the device sooner rather than later. As a result, we have developed a training program to hasten the introduction of the Airway. The training is two-part, with the first part being this presentation. To complete the training, Augusta County Fire Rescue EMS supervisors and I will be conducting station training during the month of August into September, concluding the second week of September. The station training will involve hands-on training and skill verification, as well as a written exam that will be based on the content of this presentation. The iGel is an innovative second-generation supraglottic airway device from Intersurgical. The first major development since the laryngeal mask airway, iGel has changed the face of airway management and is now widely used in anesthesia and resuscitation across the globe. Made from a medical-grade thermoplastic elastomer, iGel has been designed to create a non-inflatable anatomic seal of the pharyngeal, laryngeal, and perilaryngeal structures while avoiding compression trauma. Launched in 2007 after years of extensive research and development, iGel now has an established reputation in anesthesia with 3 adult and 4 pediatric sizes, ideal for use with the patient that weighs between 2 and over 90 kilograms. iGel is supplied in an innovative color-coded protective cradle or cage pack. The iGel is ideal for use in emergency medicine and difficult airway management, as it provides high seal pressures and reduced trauma. Plus, it incorporates a gastric channel to give additional protection against aspiration. Intersurgical also offers the iGel O2 Resus Pack, which contains everything you need to prepare, insert, and secure the iGel O2 quickly and efficiently. An iGel O2 supraglottic airway, lubricant, airway support strap, and suction tube are all included in the Resus Pack. The iGel O2 has been designed to facilitate ventilation as part of standard resuscitation protocols, or what we traditionally refer to as CPR, or cardiopulmonary resuscitation. However, the iGel O2 incorporates a supplementary oxygen port, so it can be used for the delivery of passive oxygenation or passive airway management as part of CCR, or cardiocerebral resuscitation. Furthermore, for years we have not had an option to secure the airways of infants and small children, essentially any patient under the age of approximately 2 years old, because intubation in these populations was discontinued and the combi tube and king airways used in the region had not offered an airway size for use in the pediatric patient population. For all these reasons, your medical directors and the Medical Control Review Committee have recommended a transition from the King LT supraglottic airway to the iGel airways. Let's take a few minutes to look at the iGel O2 in detail. I would like to point out at this point that there are 2 different versions of the iGel airway, the iGel O2 and the iGel. The primary difference is the iGel O2 has an oxygen port for the administration of passive oxygenation as a component of cardiocerebral resuscitation, or CCR. The iGel is designed to create a non-inflatable anatomic seal of the pharyngeal, laryngeal, and perilaryngeal structures while avoiding the compression trauma that can occur with inflatable supraglottic airway devices. This device has been developed after extensive literature searches related to supraglottic, extraglottic, periglottic, and intraglottic airway devices dating back as far as the 5th century. Dissected and preserved human cadaver models, fresh cadaver necks, and airway dissections, direct and indirect endoscopies, X-rays, CT, and MRI imaging were all studied in detail, scientifically investigated, and critically examined. This knowledge was utilized to ensure that the iGel shape, softness, and contours accurately mirror and exert the least possible pressure onto the pharyngeal, laryngeal, and perilaryngeal framework. The iGel is a truly anatomical device achieving a mirrored impression of the airway structures without causing compression or displacement trauma to the tissues and structures in the vicinity. The iGel has evolved as a device that accurately positions itself over the airway framework, providing a reliable seal and therefore no cuff inflation that is necessary. A supraglottic airway without an inflatable cuff has several potential advantages, including easier insertion, minimal risk of tissue compression, and stability after insertion. That is, no position change with cuff inflation. The buccal cavity stabilizer has a widened, elliptical, symmetrical, and laterally flattened cross-section shape, but it is still round like the airway channel, providing a good vertical stability and axial strength upon insertion. This houses a standard airway channel and a separate gastric channel. The tube section is firmer than the soft bowl of the device. The firmness of the tube section and its natural oropharyngeal curvature allows the device to be smoothly inserted by grasping the proximal end of the iGel, which helps glide the leading edge against the hard palate into the pharynx. It is not necessary to insert fingers into the mouth of the patient to achieve full insertion. The smooth contiguous undersurface of the device from the tip of the bowl and throughout the entire tube section allows the device to easily slide posteriorly along the hard palate, pharynx, and hypopharynx. A quick note on the remark that it is not necessary to insert fingers into the person's mouth primarily relates to LMAs, where the insertion procedure had you insert your fingers to push the device deep into the airway. An integrated gastric channel can provide an early indication of regurgitation, and it facilitates venting of gas from the stomach and allows for the passing of an orogastric tube to empty the stomach contents. Please note that the use of an orogastric tube is an intermediate and paramedic level skill. Next, we will examine the key components of the iGel. The device illustrated is the iGel, not the iGel O2 with the oxygen port. We will cover the iGel O2 shortly. Please understand that all of the features we are about to discuss are found on the iGel O2 as well. The cuff fits snugly onto the airway framework, mirroring the shape of the airway structures at the glottic opening. Each airway receives an impression fit, thus supporting the seal and enveloping the laryngeal inlet. The tip lies at the proximal opening of the esophagus, isolating the esophageal opening from the laryngeal inlet. The outer cuff shape ensures that blood flow to the laryngeal framework is maintained and helps reduce the possibility of neurovascular compression. Sliding past the glottic opening, it becomes narrower and deeper, creating an outward movement to fit snugly into the potential space of the surrounding glottic opening. The gastric channel runs through the device from its proximal opening at the side of the flat connector wing to the distal tip of the non-inflatable cuff. Since the distal tip of the device fits snugly and anatomically correctly into the upper esophageal opening, the distal opening of the gastric channel allows for the passing of an orogastric tube to empty the stomach contents and can facilitate the venting of gas from the stomach. The gastric channel can also provide an early indication of regurgitation. Please note that the size 1 iGel, which is the neonatal size, does not have a gastric channel. An artificial epiglottis and a protective ridge help protect the epiglottis from downfolding or obstructing the distal opening of the airway. The epiglottic ridge at the proximal end of the bowl rests at the base of the tongue, thus keeping the device from moving upwards and out of position, and the tip from moving out of the upper esophagus. The buccal cavity stabilizer has a built-in natural curvature and an inherent propensity to adapt its shape to the oropharyngeal curvature of the patient. It is anatomically widened and concaved to eliminate the potential for rotation, thereby reducing the risk of improper positioning. It also provides vertical strength to aid in insertion. The proximal end of the airway serves a number of functions. It provides a standard 15 millimeter connection to the bag valve mask and a port of entry for the gastric channel. The port is independent of the main 15 millimeter connection, and it's located on the right-hand side of the connector wing. An integral bite block below the connector runs through the center of the proximal part of the buccal cavity stabilizer. As a guide to correct positioning, the bite block is marked with a horizontal black line, which signifies the optimal position of the teeth while the device is placed. This line is not applicable to pediatric sizes. There is easy visibility of key product information, including the size and recommended weight. The information is located on the integral bite block. As mentioned earlier, the iGel O2 comes with an oxygen port for use during CCR or cardiocerebral resuscitation. To use the port, remove the cap, connect one end of a standard oxygen tube to the supplementary oxygen port of the iGel O2 and the other end to an oxygen regulator, and set the flow rate at 4 to 6 liters per minute. The iGel supraglottic airway is designed for emergency or difficult intubation in the apneic or unresponsive patient without a gag reflex. Please note, when we use the term intubation here, it simply means to generically place a tube into a hollow area. The iGel supraglottic airway is the airway of choice for the delivery of passive oxygenation during cardiocerebral resuscitation, or CCR. The airway is contraindicated if you cannot open the patient's mouth due to trismus or some other issue. The iGel is a single-use device and should not be reused. Finally, if you need to manage a patient's airway but are about to give a medicine that will likely resolve the issue causing the airway problem, for example, dextrose or Narcan, it may be best that you use less invasive methods to manage the airway in the short term. You are left to use your best judgment to determine what is in the best interest of your patient. Following are some key points for success when using the device. Do not use excessive force to insert the device. The iGel must be lubricated according to its instructions for use. The patient should always be in a sniffing position prior to insertion, with an assistant helping to keep the patient's mouth open. The leading edge of the iGel's tip must follow the curvature of the patient's hard palate upon insertion. Select the appropriate size iGel by assessing the patient's anatomy. The iGel's cuff may look smaller than traditional supraglottic devices with an inflatable cuff of the same numerical size. While size selection on a weight basis should be applicable to the majority of the patients, individual anatomical variations mean that weight guidance provided should always be considered in conjunction with a clinical assessment of the patient's anatomy. For example, patients with central obesity, where the main weight distribution is around the abdomen and the hips, might in practice require an iGel of size corresponding to the ideal body weight for their height rather than their actual body weight. Now we will discuss preparation and insertion of the airway. Open the iGel O2 package and take out the protective cradle containing the device. Remove the accessory pack containing the packet of lubricant and airway support strap from the protective cradle and place to one side. Remove the iGel O2 and transfer it to the palm of the hand in the same hand that is holding the protective cradle, supporting the device between the thumb and the index finger. Open the pack of supplied lubricant and place a small bolus onto the middle of the smooth surface of the protective cradle in preparation for lubrication. Grasp the iGel O2 with the opposite or free hand along the integral bite block and lubricate the back, sides, and front of the cuff with a thin layer of lubricant. Place the iGel O2 back into the protective cradle in preparation for insertion. Remove the iGel O2 from the protective cradle. Grasp the lubricated iGel O2 firmly along the integral bite block. Position the device so that the iGel O2 cuff outlet is facing towards the chin of the patient. The patient should be in the sniffing position with the head extended and neck flexed. The chin should be gently pressed down before proceeding. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. The tip of the airway should be located into the upper esophageal opening, which is illustrated by A, and the cuff should be located against the laryngeal framework, illustrated by B. The incisors or teeth should be resting on the integral bite block, illustrated by C. The strap should be slid under the patient's neck until the wide central band of the strap is located directly under the patient's neck. One end of the strap should be then lifted over the patient's face and secured to the iGel O2 by placing an appropriate hole in the strap over the lug of the hook ring located at the top of the integral bite block. The other end of the strap should be then lifted over the other side of the patient's face and secured in the same manner, ensuring there is sufficient tension to hold the iGel O2 securely in place, but not an excessive tension that may cause trauma to the patient's neck or face, or may cause unwanted downward pressure on the iGel O2. This unwanted downward pressure may cause an air leak. One of the experiences that EMS systems have seen is too much pressure with the strap may force the airway to bend unnaturally and may actually cause an air leak. So again, the strap should be secure and snug to keep the airway in place, but not too secure to put unwanted pressure, which again may result in an air leak. The manner in which you use the iGel following insertion will be dependent on the patient presentation. For rescue breathing and use while traditional CPR is ongoing, you will confirm placement using the standard procedures and begin ventilation. As a reminder, confirm placement by delivering several breaths with a bag valve mask while auscultating or listening over the epigastrium, then the chest bilaterally at the apices and the bases for the presence of equal bilateral lung sounds. At the same time, you should be measuring end-tidal CO2, preferably with capnography. Other confirmation techniques include observation for symmetrical chest rise and fall with each breath, looking for moisture condensation in the tube with exhaled breaths, and observing for clinical improvement in the patient. For patients with a pulse, deliver approximately 10 to 12 breaths per minute, or about 1 breath every 5 to 6 seconds. Deliver these breaths over 1 second. For CPR, deliver 6 breaths per minute for an adult and 10 breaths per minute for a child. For CCR, the iGel is incorporated using a new approach. With the iGel, we simply insert the iGel O2 airway, connect an oxygen tube to the oxygen port, and set the oxygen flow rate at 4 to 6 liters per minute. You must manually support the head in a sniffing position. This is very important to maintain the airway in an optimal position. You cannot simply insert the airway, connect the oxygen, and walk away. Finally, remember that positive pressure ventilation during CCR is prohibited. This is a blown-up view of what will be our department-specific CCR protocol, which offers 2 approaches to passive oxygenation. The preferred option is the one using the iGel. The only time option 2 should be used is when an iGel is not available. We'll now go over a few more key points for the iGel airway. Sometimes a feel of giveaway is felt before the endpoint of resistance is met when inserting the airway. This is due to the passage of the bowl of the iGel through the fascial pillars. It is important to continue to insert the device until a definitive resistance is met. Shortly, we will watch a video where this will be demonstrated. Once definitive resistance is met and the teeth are located at the integral bite block, do not repeatedly push down the iGel or apply excessive force during insertion. Again, this is key, as excessive force, especially as it is strapped down, may cause an air leak. Finally, we will watch a couple short videos produced by Intrasurgical that will provide a demonstration of the iGel O2 airway. The first will show a live view of several insertions, and the second will provide a demonstration and review of the iGel O2 Resusc Pack.
When inserting the iGel, it should be remembered that partial resistance and then a feeling of give way may sometimes be felt before the endpoint resistance is met. This is due to the passage of the bowl of the iGel through the fascial pillars. This is quite normal and consistent with correct insertion, but in such cases, insertion needs to continue until definitive resistance is felt. Let's look at some iGel insertions in real patients. Note the sniffing the morning air position and the gentle press down on the chin. See how there is no need for fingers to be inserted in the mouth. There is never a need to apply excessive force or to repeatedly push down on the device once definitive resistance has been felt.
When you arrive at the scene of a cardiac arrest, time is critical. Compressions should start as soon as possible, and any interruption to those compressions, or no flow time, should be kept to an absolute minimum. It is therefore essential that the Airway device is easy, rapid, and reliable to insert. iGel is a supraglottic airway with a non-inflatable cuff, gastric channel, and other features that make it an ideal choice for cardiac arrest in comparison to more traditional devices. One area of particular importance is the speed and ease of insertion. Unlike a laryngeal mask, there is no need to deflate an iGel cuff prior to placement or inflate after insertion. This is because the non-inflatable gel-like cuff is specially designed to mirror the anatomy over the laryngeal inlet. One recent independent study has shown iGel to be 50% faster to insert than the other devices tested, including an ET tube, ProSeal, and classic LMA. iGel could also be inserted during chest compressions. Another common concern during CPR is regurgitation and aspiration. To help combat this, iGel incorporates a gastric channel which has three primary functions. Firstly, it provides an early warning of regurgitation, as regurgitant fluid will be seen coming up the gastric channel, allowing appropriate action to be taken. Secondly, a suction tube can be passed down the gastric channel to allow emptying of fluid from the stomach. And thirdly, excess air in the stomach is vented through the gastric channel, reducing the risk of regurgitation. Seal pressure is also important in CPR, as the patient will often require a high airway pressure to enable adequate ventilation. iGel's anatomically shaped cuff accurately positions itself over the laryngeal framework, providing a superior seal to that of a standard laryngeal mask. Stability is important for out-of-hospital CPR, as the patient may be in an awkward position and need to be moved. The iGel's buccal cavity stabilizer aids this in two ways. It naturally adapts its shape to the oropharyngeal curvature of the patient and resists rotation. The iGel O2 Resus Pack includes a modified iGel with a supplementary oxygen port, a sachet of lubricant, a suction tube, and an airway support strap, all contained within a sterile pack. We will now run through the use of iGel O2 Resus Pack in a cardiac arrest scenario. First, decide on the most appropriate size of iGel O2 to use. Correct size is normally determined by weight. Open the iGel O2 Resus Pack, remove the inner tray containing the lubricant, airway support strap, and suction tube, and place the contents to one side within easy reach. Place a small bolus of lubricant on the base of the inner side of the main shell of the packaging. Touching no lower than the bite block of the iGel O2, lubricate the back, sides and front of the cuff with a thin layer of lubricant. Ensure any excess is removed. Grasp the lubricated iGel O2 firmly along the integral bite block. The ideal patient position for insertion is with the head extended and the neck flexed. But if this is not possible or is inappropriate for the patient, then iGel O2 can be inserted with the head in a neutral orientation. A proficient user can achieve insertion of iGel O2 in less than 5 seconds. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. It is not necessary to insert fingers into the patient's mouth. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force. The tip of the airway should be located into the upper esophageal opening. The cuff should be located against the laryngeal framework. The epiglottis should be held in place by the epiglottic rest. The gastric channel should open into the esophagus, and the incisors should be resting on the integral bite block. The iGel O2 should now be secured in place with the airway support strap, or taped down from maxilla to maxilla. To use the airway support strap, slide it under the patient's neck and secure it to the iGel O2 hook ring, using the appropriate holes on the strap. Ensure there is sufficient tension to hold the iGel O2 securely in place, but not excessive tension that may cause trauma to the patient. Some adjustment of the strap may be needed. A resuscitation bag can then be connected to the iGel O2 and ventilation can begin. If your resuscitation protocol incorporates chest compressions in combination with passive oxygenation, rather than positive pressure ventilation, the supplementary oxygen port provides an easy and effective method for delivering oxygen passively to the lungs. To use the supplementary oxygen port, remove the cap from the oxygen port and connect one end of a standard oxygen tube to the port and the other end to a suitable method of oxygen delivery and set to the oxygen flow shown in the instructions for use. When treatment has finished, turn off the oxygen supply, remove the oxygen tubing from the iGel O2 and replace the port cap. When iGel O2 is being used conventionally, it is important that the supplementary oxygen port remains closed. If required, a suction tube can be passed down the gastric channel to empty the stomach contents. To use the suction tube, place a small bolus of lubricant over the proximal end of the gastric channel, insert the suction tube a short way down the gastric channel, and move it up and down to prime before feeding the tube down. Many independent studies have evidenced the easy and rapid insertion, high seal pressures and improved safety offered by iGel, and it is now included in the European Resuscitation Council guidelines. The iGel O2 Resus Pack. Stay focused on what matters.
Because we are being proactive with the introduction of the iGel in advance of implementation of regional protocols, we're developing our own departmental protocols. You saw a snapshot of that when we reviewed the cardiac arrest protocols and the impact of the iGel on CCR. Later this month, we will be releasing some departmental protocols and sending out updates for the field guides. Thank you for taking the time to complete this training video on the iGel Airway. As mentioned earlier, the EMS supervisors and I will be conducting in-station training starting in the second half of August and continuing through the first 2 weeks in September. We are presently in the process of acquiring the stock of iGels, and our plan is to replace all King Airways on ACFR permitted EMS vehicles with the iGels at the same time. Our target effective date will be the second week of September. If you have any questions about the device or associated protocols, please let me know.